A big shout out to my friend Helena Liseli for making this video possible. Grab your piece of paper, grab your pen, and let's go. Hello and welcome to MK's Exam Secrets, Season 2, Episode 1. We continue with obstetrics and gynecology. This is a series on my YouTube channel where we'll look at 6 exam questions in one clinical course. Because this is obstetrics and gynecology, we're going to break down these questions into 3 questions from obstetrics and 3 questions from gynecology. You already know the rules to these videos. You can pause them at any time to actually think through the answer before I give you the answer. So let's start off with our first question. So question 1, a 24-year-old primigravida at 12 weeks presents with a scan showing twin pregnancy. Part A, list 8 clinical features that may present in this pregnancy, that she may present with in this pregnancy. Discuss 8 possible complications of twin pregnancy. What investigations would you do for her at her first visit? How would labor and delivery be managed? You may pause the video right now and write down your answers, and you can compare your answers to the marking key. Again, do not forget to subscribe if you haven't. Drop a like, hit the bell notification icon to be receiving notifications of such videos every time I post, and don't forget to tell a friend that it is exactly exam week on the channel. So here comes the answer. So remember that patients that have twin pregnancies usually have a high level of beta-HCG, beta human chorionic gonadotrophin. So this may actually cause excessive vomiting and excessive nausea, a condition that is referred to as hyperemesis gravidarum. You may get features of anemia. You may get features of early onset preeclampsia, even eclampsia. You may get late for dates. You may also get, when you palpate this individual, you may see that you may palpate too many fetal parts. They may be 2 distinct, separate fetal heart sounds. And of course, the fetal bulk is going to be disproportionately large in relation to the size of the head. And the fetus may actually be in longitudinal lie. There may actually even be some malpresentations. Now, when it comes to the possible complications of twin pregnancies, I will show you in the next slide, which is here. So you may actually group them into maternal complications and fetal complications. The maternal complications can be divided into antepartum, intrapartum, and postpartum. So antepartum, during the pregnancy, there may be some nutritional deficiencies that may lead to some nutritional anemias, such as iron and folate, that are due to an increase in demand. You may also have hyperemesis gravidarum, like I told you, due to an increase in beta-HCG. You may get preeclampsia, which is due to exposure of superabundance of chronic or chorionic villi rather. You may get polyhydramnios, especially this is common in monozygotic twins and usually involves the second sac. Then you may also get some antepartum hemorrhage that is often due to placenta abruption, which may be caused by an increase in preeclampsia, even sudden escape of liquor from rupture of the membranes. Then you may also have a placenta previa, which is because the placenta is generally larger than normal. Then you may also get some mechanical stress that may cause some palpitations, dyspnea, varicosities, even hemorrhoids. And then intrapartum complications include preterm labor, which is often due to overdistension of the uterus. You may have preterm and premature rupture of membranes. You may have malpresentations, especially in the second baby. Then you may get an increase in risk of cord prolapse, cord compression, and of course, increase in risk of operative deliveries. Then you may get some postpartum hemorrhage as a postpartum complication because of uterine atony. And you may get subinvolution where the uterus is bigger, because it was bigger than the normal size. So it doesn't shrink to, or when it shrinks, it doesn't shrink to the size that it's supposed to shrink to. Then you may get some infections that may persist after the birth, and then there may be some lactational failure, which of course is minimized by reassuring the patient and giving some additional support. Some fetal complications include prematurity, discordant twin growth. This may be due to twin-to-twin transfusion syndrome, placenta insufficiencies, intrauterine growth restrictions, which may result from either structural anomalies occurring in one fetus. You may also get intrauterine fetal death, such as fetus papyraceous or fetus compressus. You may also have disseminated intravascular coagulation, vanishing twin syndrome, which is often common in monozygotic twins. There may be some fetal anomalies such as anencephaly, hydrocephalus, microcephaly, cardiac anomalies, even Down syndrome. You may also get asphyxia in stillbirths. You may get locked twins and cord prolapse. So those are some of the complications that are associated with twin pregnancies. You can just pick 8 of them. And notice how they say discuss. And you should notice the differences between discuss and list. Notice how I'm not just listing the point, but I was saying something about the complications. Then, of course, what investigations would you do for her at her first visit? So I'll do a maternal serum alpha fetoprotein. I would also check levels of beta HCG. I'll do a full blood count and a differential count. A urinalysis, of course, to check for glucose, to check for proteins. I would also do serum urea and electrolytes. I would check the creatinine levels. I would do liver function test. For a baseline, I would also check for your random blood sugar and your fasting blood sugar to rule out diabetes. I would also do an RPR to rule out syphilis. I would also test for malaria using an RDG test, and of course, a retroviral test to rule out HIV, and an ultrasound for this patient. Then, how would you manage the labor and delivery? So when it comes to labor and delivery, remember that the partograph is going to be very important in monitoring labor. You're going to prepare 2 delivery sets and prophylactic oxytocin for this patient. Then if you do not know the chorionic or amniotic status in the gestational twins, you should treat them as dichorionic and diamniotic twin pregnancies. Then the route of delivery is actually based on the presentation in labor. So you may deliver them vaginally if both of them are in cephalic presentation, which is seen in 50% of the cases, or at least the first twin should be in a vertex presentation. Then for cephalic presentation of the first twin with no other complications, you may deliver them vaginally no later than 40 weeks. And of course, you may induce labor if indicated. For example, if you have features of oligohydramnios, intrauterine growth restriction, maternal hypertension, or any other indications that may warrant an induction of labor. Then a cesarean section is actually done if the first twin is in a non-cephalic presentation. But you get those presentations where the first twin is in cephalic and the second twin is in non-cephalic. But it's really controversial about whether you should deliver them via vaginal delivery or cesarean section. So you should ensure that the first twin is longitudinal, and non-cephalic presentations are much more common if it is early preterm labor. Then you should check for any cord prolapse when the membranes rupture, often very early in the labor. Then watch out for postpartum hemorrhage. So you should have performed active management of the 3rd stage of labor by administration of oxytocin or methadone. Remember, avoid methadone in hypertensive patients with controlled cord traction. And then, of course, give an oxytocin infusion after delivery of the second baby. Of course, you should also offer some blood transfusion for this patient. And of course, watch the patient for about 2 hours after delivery, because these patients are at high risk of developing PPH. So that's how we would manage this patient in a nutshell. Moving on to question 2, Juliet is a 38-year-old G6 para 5 at 12 weeks pregnant with no living children. All her previous pregnancies were IUFDs, intrauterine fetal deaths, that happened between 28 to 32 weeks. Patient is asking how to get her pregnant. A, discuss the various options available for fetal monitoring during the antenatal period. B, what is the biophysical profile? Describe the components of the biophysical profile. Part C, how can the well-being of a fetus be monitored in labor? You may pause the video right now to scream the answers at your screen, because who knows, you're probably revising right now. If you have no idea how to answer these questions and your exam is next week, geez, start watching the other videos as well. It may help. So here comes the answer. So the various modalities that are available for fetal monitoring are going to be depicted in the next slide, which is what I'm showing you right now. So you may have an ultrasound. So remember that ultrasounds are performed in cases of fetal surveillance that may be done either periodically throughout the pregnancy and are often used to monitor the development of the fetus as well as other intrauterine conditions. Remember, on the ultrasound, you may determine certain indices. You may determine the single deepest pool. You may determine the amniotic fluid index. You may determine the crown ramp length. You may determine other parameters that we check for, even the fetal heart rate on the ultrasound. You may also do a non-stress test, which is just simply a test that measures the fetus's heart rate and the fetal movements over a specific period of time without any external factors being applied. So for this non-stress test, the fetal heart rate is going to be monitored externally using a sensor that's going to be attached to a belt and placed on the mother's abdomen. So this test actually has no risk on the mother. It has no risk on the child. Then you may perform what is known as a contraction stress test. So this contraction stress test actually measures how the baby's heart rate is going to be responding to uterine contraction. So as with the non-stress test, you're going to be administering it with a belt sensor. But unlike with the non-stress test, you have contractions that are either physically or chemically induced, and the measurements are taken under these conditions in the contraction stress test. Then you may do a biophysical profile, which combines the ultrasound and the non-stress test to determine the baby's heart rate, the breathing, the body movements, the fetal muscle tone, and even the amount of amniotic fluid around the baby. So those are the different options that are available for fetal monitoring during the antenatal period. Then when it comes to part B, what is a biophysical profile? Describe the components of a biophysical profile. So this is actually a prenatal ultrasound evaluation of the fetal well-being, and it's going to be involving a scoring system. So the scoring system is known as the Manning score. So this is obviously done with a non-stress test. It's done when a non-stress test actually is non-reactive or for other obstetric indications. So it's going to be having predominantly 5 components. So 4 ultrasound parameters as well as a non-stress test. So it's going to evaluate things like fetal heart rate. It's going to evaluate things like fetal breathing, fetal movements, fetal tone, as well as amniotic fluid amount. Then, of course, how can the well-being of the fetus be managed in labor? So it may be managed using 3 parameters: a clinical assessment, or biophysical assessment, or biochemical assessment. So clinical is using your intermittent heart rate monitoring. This can be done actually with a Doppler sonicate. It can actually even be done with a peanut stethoscope, which is manually. You should also assess the meconium in the liquor. If it's present, this may indicate that there is some fetal distress. Then, of course, your biophysical parameters include a continuous electronic fetal monitoring, of course, with your cardiotocograph, which can be attached either externally or internally. You may also order for an ultrasound. Then there are, of course, other biochemical tests that you can order for. Then question 3, Mrs. BM, 26-year-old, was admitted in her first pregnancy at 32 weeks with an HB of 5.6 grams per deciliter. What are the possible causes of this condition in pregnancy? What clinical features may the patient present with? List 6 possible complications of this condition. How should the patient be managed? So you may pause the video right now and start screaming the answers at your screen, or you may actually even write them down. So here comes the answer. So remember that this patient is at 32 weeks gestation, so they are preterm and they have an HB of 5.6, so they have severe anemia, okay? So they have a very low HB and they're in the 3rd trimester of their pregnancy. This is, of course, the first pregnancy. So remember that what are the possible causes of this condition in pregnancy? So you may have some nutritional deficiencies that may actually be things like iron, folate deficiency, vitamin B12 deficiency. You may also have some hemorrhage that may be acute, which may be due to antepartum hemorrhage. You have chronic hemorrhage that may be pointing towards things like hookworm infestation, even hemorrhoids. You may have hereditary conditions such as sickle cell disease and thalassemias, and of course some chronic conditions like renal disease. All of these can actually contribute and cause anemia in pregnancy. Now remember that you may get these clinical features of general malaise and fatigue, exercise intolerance. You may get things like pica, which is abnormal craving of certain things. So individuals may have what is known as geophagia, where they crave soil or dirt. Then they may have pallor, they may have koilonychia, which is spoon-shaped nails. They may have glossitis, even stomatitis, angular stomatitis. You may have a soft systolic murmur, dyspnea, palpitations, and dizziness. Then list 6 possible complications of this condition. So you may have antepartum complications such as preeclampsia, intercurrent infections, heart failure, preterm labor. You may get some intrapartum complications such as uterine inertia, postpartum hemorrhage, cardiac failure, even shock. You may also get some postpartum complications like puerperosepsis, subinvolution of the uterus, poor lactations, puerperovenous thrombosis. You may even get pulmonary embolism. Then these are all maternal complications. There may also be some associated fetal complications like prematurity, low birth weight, intrauterine growth restriction, and intrauterine fetal death. So of course, you can just pick any 6 of these. This is just to help you remind you that you should be able to group these things into maternal versus fetal, and then antepartum, intrapartum, and postpartum. So how should this patient be managed? So remember that this patient is actually at 32 weeks and they have an HB of 5.6 grams per deciliter. So the first things first, you want to admit the patient and you want to investigate them adequately. So you want to do a blood film, you want to do a full blood count, you want to do your serum iron studies, so your serum iron, your total iron by day capacity, your serum ferritin, your serum folic acid levels. You also check for tests for sickle cell or even thalassemia. You should cross-match this individual because they may need a blood transfusion. They should actually receive a blood transfusion. So in the meantime, you can actually give them a blood transfusion, cover them on antibiotics. It's not routinely that we cover them on antibiotics. If there is a sign of an infection, please do not give iron. Iron is going to be exacerbating any infection. So you can give them folic acid and ferrous if they're not already taking that. Then, of course, in the first stage of labor for this patient, you want to make sure that the patient is in bed and they're lying in a comfortable position. You should administer oxygen, of course, and it should also be there because there may be some signs of hypoxia. There may also be a risk of hypoxia in this woman. Then, of course, you should have strict sepsis because this is going to be minimizing puerperal infections. And then, of course, the mode of delivery depends on indications for C-section. So anemia itself is not really an indication for delivering a patient via C-section. Then, of course, in the third stage and the second stage of labor, maintain asepsis. Then you can use prophylactic low forceps or even vacuum delivery to shorten the duration of the second stage. Then, of course, oxytocin should be given with delivery of the anterior shoulder. You should replenish the stores with a fresh packed cell transfusion, so your packed red blood cells. And, of course, postpartum, if there is a sign of infection, treat them with antibiotics. Then moving on to question 4. A 28-year-old woman presents to the gynecological clinic requesting to be screened for cervical cancer. What are the risk factors for cervical cancer? List 5 methods of screening for cervical cancer. Discuss the various treatment modalities in CIN, which is cervical intraepithelial neoplasia. So here comes the answer. So remember that the risk factors include things like persistent HPV infection with the high risk type. Remember, the low risk type is 6 and 11, which are pretty much going to be causing genital warts. The high risk types such as 16, 18, 31, 33, 35, 45 and 56 are the ones that are going to be associated with cervical cancer. Increased sexual activity. So if you get those individuals that have multiple sexual partners practicing these unsafe sexual practices, even early aged intercourse like 17 years. Why is this so? It's because the transformation zone, which is more susceptible to cervical cancer, is exposed. It's almost on the outside of the cervix, so it's easier for these cells to be infected with the HPV. Then, of course, you have some ulcerating STDs or STIs, immunosuppression, low socioeconomic status. Nothing ever good comes from being poor. Then you may also have cigarette smoking. Then the 5 modalities that are used to screen cervical cancer, you may do a pap smear test, which is by far one of the most efficient diagnostic tests that have been created in medicine up till date. You may also perform visual inspection with acetic acid, which is just pretty much vinegar. Then you may do HPV testing. You may do what is known as a Schiller's test, which uses Lugo solution or iodine. You may also perform colposcopy or diagnostic conization, which is a cone biopsy. Then when it comes to the modalities of CIN, remember that cervical intraepithelial neoplasms, you get these characteristic coelocytic changes or these changes that you're going to be seeing in the cervix. So remember, we can divide the cervix into 3 thirds. So the lower 1/3, middle 1/3, upper 1/3. Then you, of course, have the basement membrane. So if these are malignant, or I don't want to call them malignant, these changes that are affecting the cells are affecting the lower 1/3, you refer to that as CIN1. If they're affecting the lower 2/3, meaning almost like a half, then you refer to that as CIN2. Then if they're affecting even the upper third, then you call that as CIN3. If they're affecting the whole thickness of the cervix, but they haven't yet breached the basement membrane, you refer to that as carcinoma in situ. And then, of course, if they breach the basement membrane, you call that as cervical cancer, which is invasive carcinoma. So the management modalities, we can actually do observation with repeated smears and colposcopy every 4 to 6 months. This is usually reserved for the much lower variants, the CIN1, for example. You may also perform some local ablative methods like cryotherapy, which is going to be using liquid nitrogen. You can also use things like nitrous oxide or even carbon dioxide at very, very low temperatures of -70. We actually freeze those areas. Then you may also perform cold coagulation, which destroys cervical tissues with temperatures such as those displayed on the screen. You may use electrodiathermy, which cuts into the tissues using a unipolar needle. This is like a hot knife. Then you may use laser vaporization using carbon dioxide laser therapy. Then there may be some excisional methods like large loop excisional of the transition zone, or you can use loop electrosurgery excision procedures. You may also perform a cone excision, which is using a cold knife, can either use a surgical knife or a laser therapy or hot knife. Then of course you may perform hysterectomy, which may be abdominal or vaginal. And this is now to just add more information onto your brain with CIN1, CIN2, CIN3, and carcinoma in situ. These are the different modalities. I don't know what's happening to my English. Different modalities that are used to manage this patient. So you can actually pause this video, read through. I won't go through it step by step because it's going to prolong this video. So moving on to question 5. A 30-year-old woman presents to the gynecological clinic with fibroids. Broadly classify uterine fibroids. Give 3 risk factors associated with uterine fibroids. Menorrhagia is one of the symptoms of uterine fibroids. Explain how it occurs. Give 6 complications arising from uterine fibroids. Broadly outline the management options in uterine fibroids. So you may pause the video right now and scream at your screen, write down your answers, whatever you're doing. Do not forget to subscribe to the channel, drop a like on this video, drop a comment, and show some support. And here comes the answer. So when it comes to the classification of fibroids, I will show you this in the next slide. So remember that fibroids can affect the uterus, either the body of the uterus or the cervix. If it's affecting the cervix, they may be anterior, posterior, central, or lateral. Then if they're affecting the body of the uterus, they may be found just underneath the mucosa. You call that as submucosal. They are of 2 types. They have the sessile types and the pedunculated. These look like polyps. Then they may affect the muscle. They may be within the muscle wall. So you refer to those as interstitial or intramural. These are actually by far the most common. Or they may actually be just underneath the serosa. So you call that as a subserosal. They may be subserous. They may be attached to the broad ligament. You call that as a pseudofibroid. Or they may be wandering. So you call that as a parasitic. So what are some of the risk factors? Ethnicity, Black individuals, much more common than in white individuals. Nulliparity, because of course, increased estrogen exposure, unopposed estrogen exposure. Then, of course, obesity. Remember that the adipose tissue can form a form of estrogen. Then you may also have polycystic ovarian syndrome, hyperestrogenic states, combined oral contraceptive pills, those that contain estrogen. Then, of course, age between 30 to 50 and a family history of fibroids. Funny enough, smoking has actually been associated with reduction in estrogen, rather a reduction in fibroid. So I want you to comment in the section below what you find out on why smoking actually reduces the risk of fibroids, or is it fibroids or cervical cancer? I don't know what it is. Comment in the section below. I'm really interested to see what you guys find out. So menorrhagia is one of the common symptoms. Why is this common? This is very common with 2 types of fibroids. It's common with the submucous fibroids. It's common with the interstitial fibroids. Why is this so? One reason is because there is an abnormal blood supply. There may be pressure from the fibroids on the venous drainage, which increases the blood flow. That's one reason. There may be even pressure ulceration of the endometrium overlaying the submucous fibroid, which is another reason that could be leading to menorrhagia. There may be an abnormal endometrial covering overlying the endometrium that doesn't actually respond to the normal hormonal stimulations or the normal hormonal fluctuations that results in unpredictable and often intermenstrual bleeding. And then, of course, there may even be a disturbance in the balance of prostaglandin E and prostaglandin F. And remember, ulcerations is much more common with the submucous fibroids. Then 6 complications include things like severe anemia, polycythemia, infertility, sarcoma transformation, though this is rare. Abortions, these are complications associated when you have fibroids with pregnancy. Abortions, placenta abruption, intrauterine growth restriction, labor dystocia, malpresentations, postpartum hemorrhage, first trimester bleeding. Notice how they're just saying give. They're not telling you to explain anything. So note the difference between give, discuss, list, and explain. So broadly outline the management options of uterine fibroids. So remember that this can be managed medically or surgically. So surgically, you may take a conservative route, or you may take one that's non-conservative. So you may give gonadotrophin releasing hormones such as leuprolide, which can be given about 3 to 6 months to actually shrink the tumors before the surgery, and it can also be used to control bleeding. Then, of course, you may perform myomectomy, which is reserved for individuals that still want to carry out reproduction, that still want to maintain their fertility. You may also perform hysterectomy in patients that have completed parity and they have satisfied childbearing and they do not want to do any childbearing. You may perform this either abdominally, which is much more suitable for patients over 40 years, or you can do this vaginally. Then, of course, you may perform some procedures such as embolization, which is an invasive radiological procedure which uses a catheter that's placed into the vessel supplying the fibroid. Then, of course, you inject these microspheres, which are known as silicone particles, which can cause ischemia and necrosis of the fibroid. So this can actually be done. Then for patients that have heavy menstrual bleeding, you may give them tranexamic acid, mefenamic acid, combined oral contraceptive, and even antiprostaglandins, although these measures tend to be very ineffective. But mifepristone has actually been shown to be effective in shrinking the fibroids, and at a very, very low dose. But currently, it's not available for use as it can also cause endometrial hyperplasia. Moving on to our last question, question 36. 36-year-old nulliparous woman presents to the gynecological outpatient clinic with her husband because they have not been able to conceive for 5 years. Define infertility and discuss the possible causes. List and explain the investigations you would offer this couple. What are the treatment options for blocked tubes? So you may pause the video right now. Here comes the answer. So remember, there are two types of infertility: primary infertility and secondary infertility. Remember, primary infertility is inability to conceive after 12 months of unprotected sexual intercourse at frequent interval in absence of a previous pregnancy or any known reproductive pathology. Then when it comes to secondary infertility, this is just inability to conceive with 12 months of unprotected sexual intercourse at frequent intervals after previous pregnancy in the absence of any known reproductive pathology. Remember, causes may be either due to female factors or male factors. People often tend to forget about the male factors. So female factors could be ovulatory, things like primary ovarian failure, pituitary insufficiency or tumors, hyperprolactinemia, polycystic ovarian syndrome, uterine factors such as Asherman syndrome, endometrial polyps, endometrial malformations, submucosal fibroids, tubal factors such as adhesions and tubal blockage, peritoneal factors such as peritubular adhesions, endometriosis, and of course male factors such as azoospermia, which is reduced sperm count, or absence of sperms in semen, then oligospermia, reduced sperm count. Then of course you may get obstruction of the ductal system, impotence, and premature ejaculation. Then list and explain the investigations you would offer this couple. I will talk about these in length on the next slide. Then what treatment option for blocked tube? You may perform a salpingostomy, tubal reanastomosis, fimbrioplasty. You may also perform selective tubal cannulation using fluoroscopy or hysteroscopy. So here are the different investigations that you may order as indicated. So for the women, you may start off with a basal body temperature graph, which is not really an indication, or rather not really an investigation, but rather it's just going to be plotting the different temperature changes in the woman. Because remember, just before ovulation, there should be a slight rise in the basal body temperature. Then you can do a hormonal profile, because remember that hyper and hypothyroidism can cause infertility. Hyperprolactinemia can cause infertility. So you want to check for your prolactin levels. You want to check for your follicle stimulating hormones. You want to check for your luteinizing hormone, your estrogen, your estradiol, your thyroid stimulating hormone, T3 and T4. Perform a pelvic ultrasound, as this will give you an excellent view of the ovaries or the uterus in case of any pathology. You may do a hysterosalpingogram, which may actually tell you that the tubes are patent. Then, of course, you may do or may not do a diagnostic laparoscopy. Then, male factors, you want to do a serum analysis, semen analysis. You should actually submit 2 samples 4 weeks apart, and the patient should actually abstain from sexual intercourse about 3 to 4 days. You should also order for a urine microscopy culture and sensitivity in the male, serum testosterone, FSH and LH levels, and then, of course, do not forget to screen for cystic fibrosis in the male. So these are the different investigations that we're going to be ordering and the reasons why we're going to be ordering these investigations. I hope you really learned a lot, and I hope you're ready for your exams. Tell a friend to tell a friend that this is exam week. If you haven't yet subscribed, please subscribe to the channel. Until next time, my name is